So this was a presentation of CHECKMATE-032, which was a multi-cohort, multi-disease phase 1-2 study, which looked at nivolumab in combination with ipilimumab. And there were 3 cohorts with urothelial cancer that were treated, and we presented the data from that cohort today. Nivolumab monotherapy, nivolumab 1 milligram per kilogram plus ipilimumab 3 milligrams per kilogram, or nivolumab 1 milligram per kilogram and ipi 3 milligrams per kilogram. These were sequential cohorts, not all randomized, and so comparisons between the cohorts are a little bit fraught, but certainly allow generating hypothesis-driven questions. So we found that patients who were treated with nivolumab monotherapy, consistent with previous reports, had a response rate of about 25%. Patients treated with ipilimumab and nivolumab at the 1 milligram of ipilimumab, 3 milligrams of nivolumab had a response rate of about 26%. But patients treated with the opposite regimen, ipilimumab 3 milligrams per kilogram and nivolumab 1 milligram per kilogram, had a response rate of 38%, which was very promising in this platinum pre-treated disease population. We know that single-agent checkpoint blockade in general has a response rate of about approximately 15 to 20%, and so a 38% response rate stands out. One concern with this combination is toxicity, and the toxicity of the 2 ipilimumab-containing regimens seemed relatively similar to each other. There was concern that the ipilimumab 3 milligrams per kilogram regimen would be much more toxic. It was not much more toxic in this cohort. There was a slightly higher rate of some gastrointestinal toxicity, but otherwise was quite similar to the ipi-1 nivo 3 cohort, and not dramatically different than the nivolumab monotherapy cohort, which is reassuring when moving this into much larger clinical trials.
And when it comes to the patients, you mentioned that they weren't stratified randomized. Are they being tracked for response based on biomarker expression that could lead to patients?
Right. So they did evaluate patient responses based on PD-L1 status using tumor-based PD-L1 expression. If patients had 1% or higher expression of PD-L1 on their tumor cells, the response rate with the ipi-3 nivo 1 combination was 58%, compared to about 26% in patients with low PD-L1 levels with that combination. And that was similar to the other PD-L1 low, sorry, got that part. So the expression, so let me go back to the beginning of the PD-L1, yeah. So PD-L1 status was evaluated as a secondary endpoint in its impact on objective response rate. In patients who had high levels of PD-L1, objective response rate with ipi-3 nivo 1 was 58%, compared to about 25% in patients who had low levels of PD-L1 expression. Patients who had high levels of PD-L1 expression with nivo 3 ipi-1 was about 35%, so lower than that with the opposite dosing, suggesting that ipilimumab at a higher dose might lead to improved benefits in PD-L1 positive patients. In fact, a 58% objective response rate in a platinum pretreated patient population is quite high. We expect on average, again, around 20% in this patient population, suggesting that the combination might actually work best in patients with high levels of PD-L1. However, patients with low levels of PD-L1 still responded and still had durable responses, just albeit at a lower rate.
And then are these patients being tracked for any later responses?
So the studies are continuing to evaluate patients. The cohort of nivolumab monotherapy and ipi-1 nivo 3 are much more mature as they were accrued first, and so the median time since the minimum time of follow-up is about 30 to 35 months in those cohorts, whereas the minimum time of follow-up is about 8 months for the nivo 1 ipi-3. And so we're going to be monitoring over time the long-term outcomes. We did present preliminary data on progression-free survival and overall survival in the ipi-3 nivo 1 cohort. The progression-free survival was approximately 5 months compared to about 2 to 2.5 months in the other 2 ipi-nivo or nivo monotherapy cohorts, suggesting again that there's an improved progression-free survival with higher dose ipilimumab. In addition, the overall survival data suggests that the ipi-3 nivo 1 also had improved outcomes compared to the other 2 cohorts, with a 15.3-month median overall survival noted, It must be stated, though, that there was a fair amount of censoring in this cohort, and so that number may change over time. The median overall survival in the other two cohorts was approximately 8 to 9 months, so quite a substantial difference as well, but very early data. Each cohort was roughly 100 patients. The IPI-1 Nivo 3 was 102, and the IPI-3 Nivo 1 was 92 patients. So they're fairly robust sizes to give us good estimates of activity.
And then you mentioned that this data would be informing the assembly of later trials, later expansion cohorts.
Correct. So this data does inform CheckMate-032, which is a randomized phase 3 study comparing doublet immunotherapy with chemotherapy in the first-line setting for untreated patients with metastatic urothelial cancer. And they will be using the IPI-3 Nivo 1 regimen as the ipilimumab, nivolumab arm of this trial.